On behalf of the organizing team, I welcome everyone, one and all, to this webinar on challenges in conducting human challenge studies, policy perspectives from India and United States. This is the third webinar in a series of 4 webinars on ethics in clinical research being organized jointly by the National Biopharma Mission and the Department of Bioethics, National Institutes of Health Clinical Center, United States. This entire webinar series is aimed at building clinical research ethics capacity in India under the broad umbrella of the Indo-US Vaccine Action Program, a bilateral collaboration between the Department of Biotechnology, Ministry of Science and Technology, Government of India, and the National Institute of Allergy and Infectious Diseases, National Institutes of Health, United States. Biotech Consortium India Limited is assisting the National Biopharma Mission in organizing these webinars. We are pleased to have with us a distinguished panel of experts as speakers, including policymakers, researchers, bioethicists, and a large audience who are joining us through the webinar platform as well as through YouTube live streaming. To stay connected with our audience even through the virtual mode, we have some poll questions at the end of each presentation, and we urge all the participants to respond to these so that they stay connected with us. To start with the proceedings, I'm very privileged to introduce the speaker of the chair of today's webinar, Dr. Vasantha Muthuswamy, former Senior Deputy Director General, Indian Council of Medical Research India, and current President of the Forum for Ethics Review Committees in India. Dr. Vasantha's service in ICMR spans for a period of more than 3 decades in different capacities, including as the Chief of Division of Basic Medical Sciences, Traditional Medicine and Bioethics, and Division of Reproductive Health and Nutrition. She has recently taken over as the chairperson of Central Ethics Committee for Human Research under ICMR, which is specifically reviewing all COVID-19 related proposals developed and coordinated by ICMR, and released the ethical guidelines for review of research related to COVID-19 pandemic in April 2020. With these, may I request Dr. Vasantha Muthuswamy to kindly steer the proceedings. Over to you, ma'am.
Thank you, Sanchira, for this introduction. Very good morning, afternoon, and evening to all the panelists and the participants who are participating in this very, very important topic on human challenge studies. To give an introduction to this topic, to see that what it is and why are we here and what is the purpose, I'll have a very brief presentation of a few slides just to show you what it's all about. And later on, I'll hand it over to the panelists who are going to give you an excellent talk on different aspects and who have been have long experience in this particular area. The slides are visible, Dilip? Dilip?
Yes,
slides. Okay. Now, the whole webinar is on controlled human infection model studies. What are these? Most treatments, as we all know, the drugs and vaccines developed to cure infectious diseases are first tested in animals. So we always do the pre-clinical animal testing. And then before coming to the human beings, that's the regulatory procedure which is adopted. However, for many infectious diseases, animal models do not replicate the way the disease progresses in humans, and therefore a lot of interventions that are promising in animal studies do not work well in humans. The CHIM studies, that is a controlled human infection model studies, are a method to use to study infectious diseases first time in humans for the development of interventions for the diagnosis, prevention, and treatment. These studies are considered to be as an innovative mechanism to give solution to many public health issues in the globally. Now, how are these studies are done? These studies are conducted using well-characterized, attenuated strains of an infectious agent in healthy volunteers who have undergone rigorous screening and education about the proposed methodologies and the procedures, and then an informed understanding of the study before they agree to participate in these trials, and of course under tightly controlled monitoring. The CHIM studies have led to important discoveries in host pathogen interactions and are being pursued to accelerate vaccine and drug development in the world. So what is the current status of these studies? Why are we going to have this webinar today, and what's happening in this area? The CHIM studies are not new, and they have been carried out since early 1900s, it is said. Of course, people say the first study, which was done by Edward Jenner for cowpox vaccine in 1796, was also first administered in the human beings. The studies have been done for many diseases such as malaria, cholera, typhoid, dengue, etc. in the last many years. All the World Health Organization regions, that's the WHO regions, except the Eastern Mediterranean region, have countries which have conducted CHIM studies. Of course, if you take our own Southeast Asian region, where India is part of it, the studies have been conducted in Thailand for several decades for organisms causing cholera, Shigella, and other illnesses. But in India, up to date, we have not conducted any controlled human infection model studies. Of course, a multi-stakeholder, the Voluntary Infection Consortium has been constituted, and Dr. Gagandeep has been in the forefront for looking at the possibility of such studies in the country. Now, what are the challenges? What are we discussing today? There are unique ethical, scientific, safety, and regulatory challenges associated with CHIM studies. Of course, there is a consensus among ethicists who are reflected upon all these human challenge studies, and they said that because of the non-availability of many of the vaccines, intentional infection of healthy volunteers can be ethically acceptable, of course, under certain conditions. It is very interesting that very recently, in early 2020, the WHO has come out with a guidelines for ethical acceptability of CHIM studies in COVID-19 itself. And we are very fortunate that two of our speakers today, Dr. Gagandeep Kang from India and Dr. Seema Shah from US, who have participated in this consultation, and they played a leading role in the development of these guidelines. Public trust, community engagement, capacity building of all stakeholders, the researchers, the reviewers, the ethics committee members, the participants themselves, and of course the responsible media. These are all important if you really wanted to take a lead in this and start such studies in this country. The whole idea is we should have a global commitment of everybody concerned, all the stakeholders, that we want to see a disease-free world in the future, and for which the existing mechanisms are not acceptable. We have to come out with the innovative ideas. This is the whole purpose of this today's webinar. Why we are doing it, what are the issues and what are the challenges. So we are going to have excellent speakers who are leaders in these particular areas. And how are we going to address the webinar today? Is first, we are going to have Dr. Anna Darbin talking about the science of CHIM studies and what are the different studies, which are methods which have been done till date, and with an example of the dengue vaccine, where she has a lot of experience. I'll give a detail of each of the speakers before they talk. So this is just to give you a glimpse of what is the flow of presentations today. Next, we are going to have the experience from the studies conducted in US and how the various ethical challenges were handled. And this is going to be presented by Dr. Seema Shah from Northwestern University of Medical School, US. As I said, that so far in India, we have not had these studies, although we have been having some discussions in the recent time. So the Indian perspective of the CHIM studies, with the challenges which we are going to face in this, and what should be the regulatory and governance issues is going to be spoken by none other than Dr. Gagandeep Kang from CMC Vellore. She is known as a vaccine leader in this country. But the most important of all this is the public trust which has to be established, and the public concerns and the kind of public engagement and the community consultation which has to be addressed is the most important, the central role of this entire new method of doing studies. And Dr. Manjulika Vas, who is a social scientist and who has done some studies in the case of public engagement in these reviews, addressing the ethical concerns while conducting the consultation for these kind of studies, is going to give us the public perception in our last presentation. So these are going to be the flow of the presentations today. And we have made these changes from the original announcement of the flow just to see that you do understand what is the first science, what is the existing experience, what is going to be the perspectives from India, and how important is the public perception in this area. So with this, I just finished the overview of what is today's topics, and we are going to now listen to the speakers. And we'll now start with the first presentation of the day from Dr. Anne Durbin. It is my privilege to introduce the first speaker of the day, Dr. Anne Durbin. She is Professor of International Health from the Bloomberg School of Public Health in USA. She's a trained internal medicine person, especially in infectious diseases. She started her research with attenuated flavivirus vaccine in 1999, and in the last 21 years, she has to continued work in this area to work on dengue, West Nile, and malaria. Her continued work in this area is responsible for a dengue vaccine production, which has happened with the vaccine, which is a live attenuated dengue vaccine, which is capable of producing immunity to all the form of dengue types, all the 4 types of dengues. She collaborated with the National Institute of Health in USA to develop the CHIM model for dengue to study the vaccine efficacy and the immunity development. She is in many national and international boards and committees related to dengue and malaria vaccine safety. Her untiring work in this area resulted in getting her the NIH Merit Award for Translational Research, NIH Directors Award, and Vaccine Industry Excellence Award. Now it is up to you, Dr. Anna Durbin. I hand over Dr. Anna Durbin to you to see what's the role of CHIMs play in the vaccine development and the entire procedure which has been adopted.
Thank you very much.
Dr. Ann. Yeah.
Oh, thank you very much, and it's my pleasure to be here today. I'm going to start with just some general background information on challenge models or CHIM studies, why we use them, what they can do in terms of vaccine development, and what are the challenges to develop some of these models. So some of the great uses of challenge models are the down selection of candidate vaccines before phase 3 efficacy studies start in endemic countries, because we may have a large selection of different candidate vaccines, and we want to move only the best candidates forward in these large phase 3 clinical trials. I think this is really important when we look back at the dengue experience, particularly Denvaxia, because we want to identify candidates that are safe. We know from the dengue vaccine experience that a dengue vaccine that fails to protect may not just fail to reduce disease incidence, but may actually pose a greater risk for more severe disease to those vaccinated over time. So if we can reduce the numbers of candidates we put into phase 3 trials so that we're only studying those that have the best or the best safety and efficacy profile, we can accelerate vaccine development. We can also use these studies to study immune correlates of protection, and that can be very useful when we want to bridge to future or second generation vaccines. We can also use challenge studies to understand the immunologic responses to people. And I think moving forward with COVID and other diseases, it may be very important to try to understand immune responses in people who have previous infections versus those who are naive to these infections. And then the testing of therapeutics, I think that's somewhat overlooked, but also very important in terms of the use of these challenge studies. Let's see. So what are some of the examples of challenge or CHIM studies in vaccine development? RTSS, a malaria vaccine. The CHIM studies were first used to evaluate the efficacy of this candidate vaccine, and then were later used to refine the formulation and dosing regimen. Another malaria vaccine, the PFSPZ, or live attenuated circumsporozoite vaccine. Again, these challenge studies or CHIM studies for malaria were used to evaluate vaccine efficacy, as well as to define the most effective route of administration and dosing regimen. And I think it's important to note that the malaria CHIM is now a standard step in the development of malaria vaccines, and they're being developed not only for the liver stage of vaccine, but also blood stage CHIM studies are currently under development now. And then, as was mentioned earlier, we developed the CHIM study, and this was used to determine which formulation of the NIH live attenuated tetravalent dengue vaccine would be evaluated in phase 3 clinical trials in Brazil. CHIM studies have also been used in vaccine licensure, and I think this is important because we may see this in the future for other candidate vaccines. The live attenuated cholera vaccine, Vaxchora, was licensed based on efficacy data from the cholera CHIM model. And this CHIM study was critical because of the low incidence of cholera infection in travelers, made a traditional field efficacy trial non-feasible. And this trial established an immunologic correlate of protection that could be used as a regulatory criterion for immunological bridging. CHIMs used to determine vaccine efficacy, though, do not negate the need for large trials to assess vaccine safety. So where we may see future CHIM studies in vaccine licensure, those pathogens which occur very sporadically with outbreaks that pop up quickly, and which we can't really predict where the next outbreak will be to plan a phase 3 traditional efficacy studies. And examples might include, for instance, chikungunya or Zika. What are the steps in the development of a CHIM study? And I think this is really important because it sometimes is overlooked. People think you can just pull a CHIM study off the shelf and put it in and evaluate a vaccine or therapeutic in a matter of weeks or months. And it's just not the case. You have to really develop your CHIM study. You have to decide what the endpoints of your model are going to be, because these endpoints will be used to determine whether or not the vaccine is efficacious or the therapeutic is efficacious. And the endpoints used will depend upon the purpose of the model. For instance, whether you're developing a disease model, which I'll talk about in a bit, or whether you're developing an infection model. And you really need these endpoints to be reproducible so that you can power your study appropriately. So these endpoints will also be dependent upon the availability of treatment for a disease. For instance, if you're going to develop a disease model, you want to ensure that treatment is available so that you can stop the progression of disease or treat the volunteer so that they recover completely. So I said there can be two different types of models: an infection model where you're just looking to see if the pathogen infects and then you treat or halt the model, or a disease model where you actually want to see evidence of the disease that you're studying. You then need to choose the appropriate challenge strain, and this can be a wild type human isolate, or it can be recombinant strains, depending upon what is available and what the outcome of your model will be. And then you absolutely want to ensure that you have appropriately trained clinical staff who are experienced in the conduct of these challenge studies and have expertise in the pathogen under study. It's very, very important to have appropriately trained, experienced staff to conduct these studies. So an infection model is where the endpoint is verification of infection, not disease. And the malaria CHIM model is the prototype of this model. Volunteers are infected with malaria. As soon as there is parasite detectable, initially it was by blood smear, but currently being done by PCR, then treatment is given, and the volunteer, in theory, never comes down with symptomatic malaria. We developed a dengue CHIM study, and I'll talk a little bit more about that, as an infection model, not a disease model. The disease model is where the endpoint is actually a specified clinical illness, and this is typically used when infection is difficult to measure. For example, enteric challenge models and respiratory challenge models, because we know you can have infection of the mucosa with a respiratory virus or the intestinal tract with an enteric model. So it's very difficult to determine vaccine efficacy because the volunteer may be shedding these viruses from the nose or from the GI tract. And in order to prevent that shedding, it's a very, very, very high bar for vaccine development. And you may actually negate promising vaccines if your bar is to prevent challenge with a respiratory virus. Prevent infection with a respiratory virus or with an enteric bacteria. And for that reason, more clinical disease endpoints are chosen for those models. So what are the characteristics of an ideal challenge model? One, you need to induce reproducible clinical and virologic or bacteriologic endpoints in a sufficient frequency with a sufficient frequency such that the studies can be powered with relatively few numbers of volunteers, because that's one of the key advantages of these challenge studies. You can get your answer more quickly because you know sort of the incidence of the disease that you're trying to protect against with your therapeutic or with your vaccine. And in wild type natural infection, for instance, you can have a very, very low incidence of, 1 case per 1,000 people or 500 people, where with your challenge study, you're trying to induce that clinical endpoint in 80 to 100% of people. So you can challenge for efficacy with many fewer numbers. Again, you want to choose endpoints that do not put the volunteer at risk for severe disease. Whether you're doing an infection model or a disease model, you don't want to induce severe disease. The challenge must be done in a safe and ethical manner. And again, you want to induce endpoints in a reproducible manner without inducing severe disease. We chose an infection model for the reason that natural dengue infection, the majority of those natural dengue infections are asymptomatic or only mildly symptomatic. And we felt that if we were to create a disease model, it would push the model too far to severe disease and would endanger volunteers. So what are some of the limitations of challenge studies? And I think that this is important to remember because they don't answer all the questions or solve all the problems. One, the results of a challenge study may not translate to the target population of a vaccine. We enroll young, healthy adults in these challenge studies. And the results that we see in young, healthy individuals may not translate to the very young or to the very elderly. It's also important to note that vaccine and challenge time points are generally fixed and may not translate to durability of protection. And we also have a limited number of pathogen strains that we utilize in these challenge studies. So they may not, for instance, translate again to all of the number of strains or serotypes, for instance, of a specific pathogen. So how do we approach the development of the challenge strain that we're going to use? I think it's very important that we fully characterize the infectivity profile of a challenge virus or bacteria. I'm sort of focusing on viruses because of dengue, but this is also true of bacteria. What's the infectivity rate? What's the incidence of viremia in an infection model? What's the peak titer achieved and how easily is it measured? What's the duration of infection? And then we want to characterize the clinical spectrum of illness induced. What monitoring and support will be needed? Is there treatment available? And I think that's very, very important, particularly as people are talking about a COVID human challenge model now. What are the risks to third parties? Can our challenge strain be transmissible to other parties? And if so, how do we prevent that? And is special handling of the challenge strain needed? What is the biosafety level of the pathogen? Do we need certain restrictions around how we use the challenge strain? Now I'm going to talk a little bit about the dengue infection model. And again, the goal of our model was to induce viremia in a high proportion of subjects without inducing dengue fever. We started with a low dose of the pathogen, and it was a recombinant virus that we used, with a plan to dose escalate if the primary endpoint was not met. And our predefined primary endpoint was viremia by culture, detected by culture, in greater than or equal to 80% of infected subjects. We included a placebo group to better assess subjective complaints, and we hoped for a peak viremia that was only 10 to 100-fold higher than that obtained with the vaccine candidates. And that's important to reduce transmission of these challenge viruses to third parties via mosquito, and also to reduce the chance of having symptomatic illness. And then depending on the clinical symptoms and viremia that were induced, we felt future trials could be conducted as an outpatient study if, for instance, the viremia were so low that it was not transmissible by mosquito. And this was important because we can increase capacity and cohort sizes. There's limited availability, for instance, of inpatient challenge units in the US. And the ability to do these studies as outpatient studies helped us speed the program along and also reduce the cost. So this is the Dengue CHIM that was developed in collaboration with Dr. Stephen Whitehead at the National Institutes of Health. We've developed CHIM studies for Dengue 2 and Dengue 3 and are currently working on Dengue 1 and Dengue 4 CHIM studies. The viruses were derived from strains that caused only mild clinical illness in the wild. So these were the parent strains of these viruses were described as naturally attenuated viruses. The Dengue 2 and Dengue 3 challenge strains were actually failed vaccine candidates. So they were not attenuated when they were compared with the wild type parent strain, and they both contain a 30 nucleotide deletion in the 3' untranslated region, which was introduced to develop a vaccine strain. But as I said, these strains were not attenuated in the non-human primate model, so they were abandoned as vaccine strains, but were repurposed as challenge strains. Both of these challenge strains induced viremia in 10 out of 10 subjects in the pilot study. We also saw a rash in 8 of 10 subjects for both of these challenge viruses. They were then moved forward or advanced to evaluate the protective efficacy of the live attenuated tetravalent dengue vaccine. And the primary endpoint of the vaccination followed by challenge study, again, was the protection against viremia, with protection against rash and neutropenia as secondary endpoints. And they were powered for 60% efficacy against viremia, with the initial assumption that we would see viremia in only 80% of controls. When we looked at only the primary endpoint, this would allow us to enroll only 10 subjects in both groups to show efficacy. But we did also want to look at efficacy against rash, so we increased the number of volunteers to 24 in each group. When we looked at protection, and this is looking at 2 different studies that we did with the Dengue 2 Delta 30 challenge virus and comparing it with the Dengue 2, with 3 different challenge studies with the Dengue 2 Delta 30 virus, what we see is very reproducible results. We've gotten viremia in 100% of subjects in each of these studies. The peak titer, mean peak titer, is very reproducible at between 2, essentially, and 2.5 logs, with good onset and duration of viremia. So again, very reproducible, which helps us power our studies. When we look at the Dengue 3, again, we see viremia. When we gave it at 3 logs, we saw viremia in 100% of individuals, 80% rash. We had a bit of a lower mean peak titer here at essentially 1.8 logs, so we went up in dose to 4 logs and surprisingly saw a decrease in the percentage of subjects with viremia and a lower titer. So we've decided to move forward with the 3 log dose of this challenge virus. But again, seeing viremia in 100% of individuals and rash in 80% makes it easy to power these studies. And then when we look at protection against against challenge in these vaccine recipients, we see that the vaccine induced 100% protection against both viremia here and rash in the challenge model. These individuals received vaccine and then were challenged 6 months later with the Dengue 2 Delta 30 challenge virus. So in summary, I think it's important to note that clinical endpoints should be chosen to ensure that the challenge study can answer the questions for which the model was developed. And that's very, very important. You want to develop the questions that you want your challenge model to answer, and then you want to go on and figure out how you're going to develop that model, what type of model it should be, and what are those specific endpoints that you're going to need to include in your model. Different models may be needed depending on the pathogen you're studying. Again, disease models may be more appropriate for vaccines for mucosal pathogens, as prevention of infection may be too high a bar for a vaccine when we're looking at, for instance, respiratory pathogens or enteric pathogens. And an infection model may be preferable for other pathogens such as dengue and malaria. An experienced clinical trial team and appropriate infrastructure for the conduct of the challenge studies are critical to the success of this study. I can't stress that enough. You need to have people who are very experienced in the conduct of these studies. And although there are limitations to challenge studies, they can be extremely useful for vaccine development as well as for therapeutics development. And that is the end of my presentation. And we can have, I guess, questions in the chat function or later in the discussion. Thank you.
Yes. Thank you, Dr. Anna, for this excellent presentation. We'll have the question answer at the end of all the presentations. Yes. I hand over to Dr. Sanchita for the
Thank you, ma'am. We'll have 2 poll questions right now. You see the first question on your screen. Please respond. CHIM studies for infectious diseases are planned to produce infection in volunteers, disease in volunteers, both A and B, either A or B. This is the response that we see. The correct answer is D, option D. Can we have the next poll question, please? The target volunteers for CHIM studies are any age group from young to old, young healthy adults, those who had the disease earlier once, or both the options B and C, that is the second and third. So this is the response. Young healthy adults is the right answer. Thank you, audience. With this, I hand it over to Dr. Vasanta. Ma'am, over to you.
Yeah. Thank you, Dr. Sanchita. So we now move on to the next speaker, Dr. Seema Shah, for giving her experience to us about the studies which have been done and how they are able to handle the ethical challenges. Dr. Shah is an associate professor of pediatrics at the Northwestern Medical School in US, and she is also the associate director of the bioethics program at Lurie's Children's Hospital. She is an expert in pediatrics as well as global health research ethics. Her main focus is around the question, is it ethically and legally acceptable to expose some people to risk for the benefit of others? Of course, she is well qualified to address this question because she is a law graduate from Stanford University Law School, and she has completed a bioethics fellowship from the NIH Clinical Center. So she has a legal background and ethics background, as well as she is working as a pediatrician. She has been the faculty at the University of Washington Seattle Children's Hospital, as well as in the NIH Clinical Center. She has chaired the NIH Committee on Ethical Considerations in conducting Zika virus human challenge studies. And here she is going to share with us her experiences in this area for the last so many years. Over to you, Seema.
Thank you for that introduction. Can you all hear me?
Yes.
Great. And you can see my slides as well? Wonderful. So it's a pleasure to be here this morning. For me, at least it's the morning. I also wanted to thank the organizers for having me here and look forward to a day when we can do something like this again in person. So my task is easy because I get to follow these two excellent presentations. I'll be focusing in on the ethics of challenge studies. And the first thing I would like to do is make a quick note about terminology. So you'll hear many people using different terms to refer to essentially the same thing. I often use the term controlled human infection studies. You heard Dr. Durbin using the term controlled human infection models. Sometimes people distinguish creating the model, which can then be used to test vaccines or therapeutics or other, learn more about early phases of a disease. But she gave a nice presentation to show how the model is the first step in setting up and being prepared to do other things. People frequently use the term human challenge trials, and I will do that as well. And the Wellcome Trust recently did a report where they recommended the use of the term voluntary infection studies. I like to use this picture because it's from a study that was done in the 1970s at the University of Maryland, which was a cholera controlled human infection study. And you'll see that this volunteer is holding up a sign with the number 26. And that's because he took 26 liters of intravenous fluid to recover from his infection of cholera, but has recovered quite nicely, as you see here. And this, I think, illustrates that these studies can be quite burdensome for the participants who are involved. When we look back to the long scientific history, which Dr. Muthuswamy did a really nice job of talking about very briefly, one of the interesting things to note is that there's been this long history, which includes some very promising studies that have made major scientific advancements and others that were quite controversial. But despite this very important history, the first ethics article on the ethics of controlled human infection studies was written by Christine Grady, who you saw earlier, and Frank Miller in as late as 2001. So ethics in this field has really been playing catch up to the science. I think the first question a lot of people ask is, are these studies ethically unique? It just sounds strange to think about scientists deliberately infecting participants. People often worry that physicians have the obligation to do no harm, so it can't possibly be ethical for physicians to deliberately infect participants. But if you look to the ethical consensus in the literature, at least before COVID, it was pretty clear that controlled human infection studies are not actually ethically distinct from other types of research. So in general, in research, we think it's okay to expose some people to risk for the benefit of others. If you consider phase 1 trials in healthy volunteers, these studies test drugs or treatments to try and see if they work, or to see if they're safe, rather. And doing that doesn't require benefiting the participants. The goal is to benefit other patients in the future. So this general balance of trading off individual risk and societal benefit is present in research everywhere you look. And the key is making sure that that trade-off is going to produce socially valuable knowledge, and that the people who are involved understand what they're getting into and give their voluntary informed consent. But I'll talk a little bit more about the conditions for making this trade-off later. People also agreed that some controlled human infection studies were too risky to permit. And two of the questions that were often asked in the earlier papers were, first, is there a curative treatment that's available, or is the disease self-limiting? In other words, would it resolve on its own after supportive care was provided? The one counterexamples of this is influenza controlled human infection studies, which have been conducted for a long time and have been very useful in producing correlates of protection against influenza. But these studies do not really meet these two criteria. So it's an interesting distinction between what's in the literature and what a commonly used controlled human infection study. And then people also agreed that, like other research, there were several ethical considerations to apply to decide whether controlled human infection studies were ethically acceptable. And what's been fascinating about this current moment in history is that we're at a point where controlled human infection studies have gone big on the world stage. So in this is an old article which says why have 14,000 people volunteered to be infected with coronavirus that came out early in March or April. But this article really, if you were to be updated now, the numbers are closer to 36,000 people who've signed up to an organization called One Day Sooner to say that they would like to participate. And some proposed using these controlled human infection studies to address COVID-19. Just this week, the UK government announced that they have made concrete plans to use controlled human infection studies for COVID-19. And I won't talk much about this in my presentation. I think there's a lot of skepticism about whether these studies are necessary, but there are some interesting potential uses of these studies to test second-generation vaccines, which is a use that Dr. Durbin spoke about briefly. So it's a really interesting time where people are paying attention to controlled human infection studies. But for our purposes, I think the important thing to recognize is that all of this discussion has kind of ignored the fact that, or at least not paid sufficient attention to the fact that these studies, although they're not unique, and although they're very important, they also raise a constellation of difficult and unresolved issues in research ethics that we've been thinking about for a long time, but that we haven't resolved. So if you consider the right to withdraw from research, it's generally accepted that everyone has the right to withdraw at any time without encumbrance. However, if somebody were to withdraw from a controlled human infection study and they were infected with a disease, they could then pass that on to others and cause risks to third parties outside of the research. So the problem is, I think, that both the right to withdraw and this issue of third-party risk are two things that are not really balanced or clearly stated how you would balance them in regulations and ethics guidance. Additionally, there's been a general presumption of excluding vulnerable participants from risky research, but that can lead to denying populations of those vulnerable groups benefits from research down the road. So people are starting to revisit the categorical exclusion of vulnerable participants from research of certain kinds of risky research. And what that means for controlled human infection studies is not very clear. Finally, there's long been a debate on whether there's an upper limit of risk in research, and if so, what that upper limit of risk is. And controlled human infection studies also struggle with that same question. So our group decided that it was important to develop a more rigorous, comprehensive ethical framework with support from a few different foundations and in partnership with the World Health Organization to produce the key criteria document that you saw Dr. Vasanta present. And what's interesting about this group, I think, one of the most remarkable things about it is this group involved human challenge study researchers and ethicists. And we initially, this is the first in-person meeting of our group, initially it was a little difficult to have those conversations happen across disciplines, but over time the collaboration was really impressive to see. And what that has resulted in so far, sorry, looks like there's some kind of window that's pausing my screen sharing. Does anyone know why that happened? Okay, it looks like we're back. If you'll just give me a moment. Okay. So our group came together to develop an ethical framework, and what we did was we rapidly repurposed this for COVID-19. So this first paper is a paper in Science, which was the presentation of our ethical framework as it applied to COVID-19. We also worked with others at the World Health Organization to develop this key criteria document, including Dr. Kang. And then finally, we have a special issue on the ethics of controlled human infection studies. Every article in that special issue has input from a challenge study researcher and an ethicist, and it just came out this month. So here's our ethical framework, and now I'll walk through each of these quickly to give you a sense of how these principles fit together. So first, social value. This is the idea that the magnitude, distribution, and likelihood of health benefits from research for populations is what gives research its value, and it's important to ensure that research has sufficient social value before it proceeds. However, what's interesting is that most of the time this is kind of an ad hoc judgment that review committees will do, but when there are high risk and high potential controversy from studies, such as studies that would look at SARS-CoV-2 in controlled human infection, there's a need to be more rigorous and actually be able to delineate a path from controlled human infection studies to the health benefits that they would produce. And the risks and benefits, the next issue then is to look at the risk-benefit ratio. So risks and benefits to participants should be systematically identified, evaluated, and minimized. And this includes compensation for research-related injury. So if a participant becomes injured, they should receive prompt access to treatment and also have compensation for any harms that are longer-term harms, including potentially lost wages. This is something that the United States doesn't have great regulation on, and of course, you'll hear from others about the Indian regulations, but the Indian regulations that have are quite comprehensive on this topic. There is this interesting question about risks to third parties because there's very limited guidance in regulations about what to do about people who haven't actually consented to participation in research, but are still being exposed to risk. In my view, I think the key is noting that even low probability and high magnitude risks may raise concerns because risks are a product of how likely they are to happen and how bad they are. So it's important to note that. However, when we think about risks to third parties, one of the challenges is figuring out how to manage the importance of preserving trust, because risks to people outside of the study may threaten public trust more than risks to people who've given their consent for participation. And these risks may be addressed through inclusion and exclusion criteria in many cases. For instance, participants who work or live with young children or infants might be excluded in cases where the transmission of the disease to those populations could cause serious harms. One other challenge is figuring out how to balance risk with the individual participant's right to withdraw. Controlled human infection studies often involve confinement. This can be about 17 days or up to 29 days in some cases. And it seems important to first minimize the risk of withdrawal with appropriate participant selection and a robust informed consent process that lets people know what they're getting into and make sure that something that they could have anticipated coming up is addressed in advance so that they don't withdraw. If withdrawal from research would be unacceptably risky, then perhaps that research shouldn't be done. But in the event of withdrawal happening, despite all of those precautions, it's good to encourage for participants to take steps to protect others, abide by legal restrictions under a public health authority, which might include reporting to a public health authority or requiring isolation under that authority. The third prong is to think about site selection, and here there are a number of factors to consider. Dr. Durbin focused on a few of those in her presentation as well, so I'll just go through them quickly. One is what the nature of the scientific question is, the second is whether the study can contribute to capacity building or there's a need to build capacity in the place where it's being conducted. Whether there's expertise in treating the disease locally can also be quite beneficial. Whether recruitment would be feasible, if there would be risks to third parties that might be difficult to protect in the environment. And finally, whether there's local social value from doing this study if the disease in question is something that has a big burden in the place where it's being studied, and what the stakeholder views are on using these studies in this place, which you'll hear more about later. So for the next prong is to think about participant selection. For controlled human infection studies that don't offer the prospect of direct benefit, selecting people fairly to participate really requires thinking about inclusion of clinically relevant populations and exclusion of those who would face unacceptably high risks, either for themselves or for third parties. And in each slide, I'm giving you the citations that are relevant. All the ones in blue that you see are from our special issue. Fifth is community engagement, and I won't speak much about this because you'll hear more about stakeholder engagement in just a moment, but it's important to recognize that it's context specific and that more engagement may be needed in certain cases. And one interesting point is that embedded social science can be very useful as the field is developing. One great example of that is Dorcas Kamuya's work in Kenya, where they've done an incredible amount of embedded ethics research to reveal different ways that participants actually experience participation in these studies. Sixth is robust informed consent. And the goal here, I think, is to recognize that there's been a lot of research done on how to improve informed consent. So the use of evidence-based methods can, in fact, enhance understanding. There are certain key elements for controlled human infection studies, such as the fact that people will be exposed to an infection, the burdens and risks for them, including those that are uncertain or presently unknown, that there might be risks to third parties and any restrictions on liberties that come out of the risks to third parties and the need to protect others outside of research. And finally, in this paper below, which I collaborated on with Veena Vaswani and Ava Saxena. The idea is that blanket restrictions on populations on the basis of low literacy or education are not justified, that people can, with a robust and informed consent process, get to a point where they have good understanding, even if they aren't literate or aren't as well educated as others. Finally, we thought it was important to focus on sufficient payment because there's considerable potential for controversy. In Kenya, this has been experienced where this study came out as a controlled human infection. This article in a newspaper came out as a study was being conducted. And interestingly, after the article came out, they had more people calling to join the research than they could actually fit within the research. I think although there's this potential for controversy, it's important to compensate participants for their time and expenses to avoid exploiting them or asking them to bear the burdens of research. Participants should also receive treatment and compensation for injury if it occurs. Some people have advocated for paying for risk up front, but this isn't something that I advocate for. I think it makes more sense to make sure people are covered if they do become harmed. And finally, it's important to think about the fact that sometimes people might be so tempted by the money that they withhold information that would make them ineligible. We found that this did happen to some degree, or could have happened in a qualitative study we did in controlled human malaria infection study volunteers. And I think the key here is just to develop objective eligibility criteria that don't depend on what someone tells you. And also remind participants of the importance of telling the truth about certain things so that they know that their own safety actually matters. So the takeaways I want you to leave here with are first the idea that controlled human infection studies are not ethically distinct from other research necessarily, even though they feel different. They have the same balance of individuals taking on risk for the benefit of others in society. But they can raise several issues that have not been fully resolved by the ethics literature and existing regulations. Their social value is complicated and it depends on how they fit into a larger research portfolio. Ultimately is key to the justification of these studies and should be balanced against the risk. Finally, they can be ethically acceptable if several criteria are addressed and there's robust review and consent processes in place. I'd like to acknowledge our wonderful team who worked on this for quite a few years before it was really even a popular thing to work on, and just leave you with the framework that we developed. I think we'll return to questions much later. Thank you.
Thank you very much, Dr. Seema, for clarifying many of the doubts which many people must be having in their mind. Thank you so much. The question and answer will be at the end of the session. I hand over to Dr. Sanchita.
Thank you,
For
ma'am.
the poll questions now. Yeah.
This is the first poll question. Challenge trials raise ethical questions that are completely new but easy to address, not new and easy to address, not new but not fully resolved. D is the right answer. 64% of people have responded. Can we have the next question, please? The benefit for society from challenge trials is not as important as the risk, important to balance against the risk, irrelevant to whether they should be approved, always going to be minimal. So B is the right answer. 91% is the response. Thank you, audience. Over to you, ma'am, for the next presentation.
Yes. Thank you, Dr. Sanchita. We now move on to the next panelist, Dr. Gagandeep Kang. Dr. Kang is trained in medicine and microbiology from CMC Vellore in India, and where she is currently working as professor of microbiology. She is the first woman scientist from India to be elected as a fellow of the Royal Society in UK, and she is also the first Indian woman to be elected to the fellowship of the American Academy of Microbiology. She has many firsts to her credit. She works on enteric infections in children, particularly in transmission and immune responses in order to design effective interventions. She is well known in the country for conducting the rotavirus vaccine trials in children. For her contributions in this area, she was awarded the prestigious Infosys Prize for Life Sciences. Again, she is the first of a kind that she is the only physician scientist to get this award in this country. She is currently focusing on viral and parasitic enteric infections in children, especially related to the hospital and community surveillance programs in children. Over to you, Dr. Khan.
Thank you, Dr. Vasantha, for the introduction. I'm going to be speaking about challenges in governance and regulation of controlled human infection models with a particular view to India. We've had a really nice setup from Anna and Seema telling us about the value of human infection studies and telling us about the ethical considerations that we should have. But I think when we look at talking about them in India, there are always questions asked. And these questions are, well, you know, if other people are doing them, why should we consider doing them in India? Our research infrastructure is not very good. How can we trust our researchers to actually do a good job and not use our people as guinea pigs? So with that construct, the questions break down into, do we really need such studies? What is the goal? Why should we be doing them in our country? Should we be doing them when they are for science alone? Or can we consider them when there is a product such as drugs or vaccines? Should we do them for diseases that affect us alone? Or should we do them for diseases that also are present in other parts of the world? In which case, why should we be doing them? Who will do the studies? And then we are told, of course, that in India, nobody will volunteer. And the reasons that people will volunteer will only be because they will be paid for it. And the issues that we are likely to encounter are usually described in very, very great detail. Most of those issues actually relate to the conduct of clinical research and are not restricted to the idea of human infection studies. We know now that doing controlled human infection studies has become a core methodology in modern infectious disease research. It's not done for every disease and for every situation, but in those where it is done, there is fundamental scientific value to be able to doing these studies, because if we think about infectious diseases, being able to control the dose and the timing of infection and to study interventions in well-characterized human subjects really gives you a greater understanding of the disease process and the mechanisms by which interventions work, rather than relying on model systems in cells or in animals. And now we have tools that are available to us that we've never had before. The kind of immunology, the kind of genomic studies, microbiome studies, all the various omics, the tracking of drugs over time and by dose. These are not things that we were capable of doing a couple of decades ago. And the amount of information that we can get from a small number of individuals has really expanded greatly. So if this is an area of accepted scientific exploration, should we be closing that off for India? Now, just to say that actually controlled human infection is not new to India. This is a paper that was published in The Lancet, and for many people who are attending this webinar, I'm sure you will recognize some of the names here. Hepatitis E virus is a virus that could not be grown in any animal system. To study it was very difficult. The only infections you could find were the ones that were in patients, and therefore tracking events over time was challenging. And here we have a report of a single volunteer who was infected with hepatitis E virus and used himself to track what happened over a period of 2 years. So this was obviously a single person study and not a trial, but these have happened before anecdotally. Now, if we look at controlled human infection studies, they do have limitations because they are in a small number of people. They may not always be generalizable. And particularly if we are thinking about vaccines, then the duration of a human challenge study is often designed only to assess short-term protection, short-term meaning a few months at most. There are, of course, further challenges in that when you set up experiments, they differ from natural infection, and there can be issues around how that is done. But if we look at generalizability, one of the critical aspects that we need to consider in a country like ours is the fact that prior exposure can influence the response to vaccines. Not all vaccines, but some of them. So, for example, if you had a vaccine that was developed and tested in a high-income population, it would not perform the same in all locations. Examples of that are malaria, where what you see in the US in malaria is not replicated in Kenya. And similarly for rotavirus, again, we know that what you see with infection and disease and the performance of vaccines in the US, is very different from what happens in India. So if we look briefly at regulatory requirements in the US, any live organism is considered a biologic and it's subject to FDA regulations, safety testing, and documentation on manufacturing. There has been a lot of discussion around whether if you make a challenge agent, which needs to be very carefully done, as Anna pointed out, can it be something that has to fit current GMP, or can it be something that is GMP-like? This was a subject of debate among researchers for a while, and I think now there is increasing consensus to say that while the wording in documents might be a little bit different, most regulators actually mean the same thing, which is as far as possible, you have to follow good manufacturing practice. Now, in the European Economic Area, human challenge studies are considered, the challenge agent is considered a non-investigational medicinal product. The WHO recommendations were published in 2016 related directly to the use of challenge studies in vaccines, and these were by the Expert Committee on Biological Standards, saying that data could be generated from human challenge studies and could be used from human challenge studies, but there would be a requirement for additional safety data, as Anna also pointed out. Subsequent to that, there has been the specific guidance that you heard about from SEMA, which was published in 2020 relating specifically to SARS-CoV-2. In India, there is no specific regulation as yet that defines the use of human infection studies. A malaria model was discussed at ICMR several years ago with the participation of the drug controller. And in principle, it was approved, but that never moved forward. In 2019, we had the new drug and clinical trial rules issued by the government. And these were aimed at promoting clinical research in the country so that there could be a transparent and faster approvals process for clinical trials. This new set of rules is applicable to all new drugs, to ethics committees, to investigational new drugs which are intended for human use, for clinical trials and bioequivalence studies. The principles are laid out very clearly. The goal is faster process and increase access for new products for use in India. If we look at what is contained in these rules, a few things have changed. For example, if we look at investigational new drug, the old definition was a new chemical entity or product with therapeutic indications, but which had never been tested earlier on human beings. And the new definition is a new chemical or biological agent or substance that has not been approved for marketing in any country. There are exclusions to what is a new drug for certain classes of compounds. And since we are talking about human infection studies, many of these will relate to vaccines. So vaccines and recombinant DNA products and monoclonal antibodies are always classified as new drugs. If we look at other definitions that may be important to us in thinking about human infection studies, these include what is a definition of a new chemical entity, and that is any substance not approved as a drug in any country or proposed to be developed as a drug for the first time. An investigational product, and this is very important for us, as opposed to an investigational new drug. An investigational product is a pharmaceutical formulation of an active ingredient or placebo being tested or used in a clinical trial. So when we think about a vaccine in a challenge study, the vaccine will be the investigational new drug, whereas the challenge agent would be an investigational product which is used in the clinical trial. So if we look at the regulation of biomedical and health research, before the new rules were issued, there was no regulation that had been stated by the government. Now, Chapter 4 is a separate chapter in the rules for regulation of biomedical and health research. And it states that this is to be conducted in accordance with the National Ethical Guidelines for Biomedical and Health Research involving human participants, which is issued by ICMR. Dr. Vasantha Muthuswamy was responsible for the first such guidance that was made by ICMR. Now, when we look at which ethics committees can review such studies, it appears because you're going to use an investigational new drug and an investigational product, it will have to be ethics committees for clinical trials rather than ethics committees for biomedical research. And these are, and the distinction is very important because many academic organizations may only do academic clinical trials and studies that are not trials at all, whereas an ethics committee for clinical trials as defined in the new rules will deal with regulatory clinical trials as well as academic clinical trials. And very importantly, the compensation for such clinical trials will follow the norms that have been established by the Drug Controller General of India under the Central Drug Standards Control Organization. So the Ethics Committee will need to be registered with CDSCO and follow the guidance related to regulatory clinical trials. So DBT has been very engaged in the discussions around human infection studies for a number of reasons, and this webinar is also part of the Indo-US Vaccine Action Program. So if we look at funding, the Department of Biotechnology provides funding for different kinds of programs that are related to vaccine research, not currently for any human infection studies, except for what is built into the DBT EU, next generation influenza vaccine programs that have been funded. The other area is Indo-US Vaccine Action Program, where this ethics discussion is taking place. And what has been discussed, and Anna's been part of those discussions for a while, is to ensure that there is training for regulators, for researchers, and for people who will be responsible for the governance of such studies in partnership with NIH and NIH-supported centers in the US. In terms of consultation and regulatory support, the Department of Biotechnology was part of the discussion for this and for several other discussions that have been had prior to the Access to Medical Products meeting in 2019. In terms of governance, a white paper for consideration of human infection studies was released at the Access to Medical Products meeting, and this was developed by the Translational Health Science and Technology Institute in consultation with multiple stakeholders, many of whom are on the panel and have been engaged in several discussions before that. I think I just lost my slides. So can you see my slides now or not? You can?
Yeah, we are in the slide on the DBT's role. That slide is there.
Yes.
Yeah.
So moving on from DBT's role, I think Dr. Vasantha had pointed out that we have brought together multiple stakeholders at multiple meetings, and listed here is just a long list of all the meetings that have happened in India to discuss human infection models. I missed on this slide that there was a meeting that was hosted by the Indian Council for Medical Research a couple of months ago, at which there were several speakers, including Dr. Fauci and Dr. Stanley Plotkin, who had different views on the use of human infection studies in SARS-CoV-2 vaccine development. Our media has also been very engaged in the discussions and in listening to the idea of doing human infection studies, and they are divided. There are people who say that this is a good thing and should be considered, and there are others who think that this is unethical clinical practice. Moving to questions of monitoring and governance of relevance to India, I think in terms of evaluation, CIMA has done an outstanding job of describing what needs to be considered, but specifically for India, scientific value and relevance are very, very important. Community engagement in India is always challenging given how stratified our communities are and the lack of communication there frequently is between different stakeholders. So thinking about how to engage them, much as has been done in Africa, would be extremely valuable. Risk-benefit considerations, third-party risk, and environmental considerations have also been dealt with by CIMA. I think the one thing that is most important to emphasize when thinking about human challenge studies, whether we do it for the purpose of understanding more about a disease or to look at moving products forward faster, is the idea of trust and transparency. Without complete transparency, without trust between all stakeholders, this is just not going to be possible. Obviously, when we think about doing these studies, we look for the highest quality care to make sure that the process is safe and therefore the most experienced investigators. And this, people argue in India, no one has experience with human challenge studies. We don't, but there is no reason why we cannot learn from others in other parts of the world. So far, one thing that really is missing is clear approval pathways, and it would be very valuable if DBT and CDSCO and ICMR could take this forward so that investigators who are interested in conducting such studies have a way to move forward. In terms of monitoring, obviously for regulatory clinical trials, CDSCO is responsible for the external monitoring beyond what is set up by the investigators. But I wonder whether it might be a good idea to develop a pathway that requires also perhaps the ICMR Central Ethics Committee or equivalent, as well as a community monitoring mechanism similar to the community advisory boards that we have for other studies. In terms of compensation, I think compensation for burden is something that needs to be appropriately quantified, and there has been discussion about what this should constitute, and compensation has been proposed. Compensation for harm, again, is something that I don't think, or for risk, I don't think is something that should be dealt with until harm is actually identified. And for that, the structures that we have in place in India have been quite well developed, but it would be useful to see whether a revision in the context of human infection studies would be valuable. So to summarize, human infection models are used widely in industrialized countries, and this is not just for diseases relevant only to them, but also for diseases that are relevant to other parts of the world. If we review the regulatory requirements in India, it indicates that CHIMs should be reviewed as regulatory clinical trials, whether or not a product is tested. Discussions in India have been ongoing for almost 3 years now, and it would be good to see some movement in this area.
Thank you very much, Dr. Khan, for this excellent presentation, giving the challenges globally as well as what is to be done in India. Yes, we have been having discussions in a small group of people. I think now with the participants will understand that yes, we are not lagging behind in the discussions in this which is happening, and the way forward is going to be very soon. It should be there. With this, thank you very much, and I now move on to Sanchita for conducting the next poll after Dr. Khan's lectures.
Sure. So the poll question is on the screen. Which virus was deliberately taken by a volunteer in India? Hepatitis A, B, C, or E? 60% got it right, hepatitis E. We move on to the next poll question. Under the NDCT 2019, a challenge agent could be classified as new chemical entity, investigational new drug, investigational product, or don't know. Investigational product is the right answer. 31% responded correctly. Thank you, audience. Over to you, ma'am.
Yes. Thank you, Sanchita. We now move on to the last speaker of today's webinar. But then I think that's the most important topic, as was pointed out by all the earlier speakers, that the public trust in starting something which is new, which is a new methodology, which has got so many concerns about the people. The most important, how to gain the public trust to get into these areas. So we are going to have an excellent talk by Dr. Manjulika Vas, who is a social science researcher at the Division of Health and Humanities at the St. John's Research Institute, Bangalore, which is part of the St. John's National Academy of Health Sciences. She works at the interface of medical research and ethics, science, and society. Her focus is mainly on public engagement and people-centered ethics. Her doctoral thesis was in the area of public perceptions and biobanking, which has influenced various guidelines in this area. She works with medical students to humanize their perceptions of medicine and health. She is member of many ethics committees and interdisciplinary networks. Her publications span the domains of ethics, public engagement, public health, and humanities. She has a lot of experience in this area and excellent publications. And she is going to talk to us about the community engagement in novel medical research and what is the people's voice, which she has experienced by conducting a large number of studies, which she has published also. Over to Dr. Manjulika.
Thank you very much, Dr. Vasanta. I am happy and grateful to be part of this panel and to be here today. I feel a sense of responsibility as well. I'm actually going to be raising the voice of people who are otherwise less heard in such fora. So I do feel a privilege and an opportunity to raise their voice today. I like the context that Dr. Gagandeep has set, which is wider than challenge studies. And that's really the context in which we need to understand what the public feels about ethics. What do they understand about ethical research? What do they understand about clinical research? Is it to do with people's informed consent, signing that document? Is it to do with conforming to, fulfilling the ethical requirements, regulatory requirements, what ethics committees review and look at? People actually feel consent actually protects the researcher, the research institution. They actually question, is consent actually protecting me? Interestingly, what the concern of people is, are they being heard? Their views, their perceptions, their expectations, their apprehensions, are they being responded to? Is there honesty and transparency in the communication? Or is it just more information that they are overloaded with? Is that considered transparency? Issues to do with what are the motives, the underlying purpose of the research? Why are we not shared that information about the compensation, who is funding the research? And that is actually the basis of building a relationship between researchers and the public, between science and society. And that is actually the backbone of what is required in ethical research, which is building trust. This area, Dr. Vasanta has mentioned, is something I've been working on for the last 7 to 8 years. And one of the early publications that talks about this in greater detail is listening to the voices of the general public in the wider context of biomedical research. So that's really the background. And I think it's important to understand that when we are talking about challenge studies in India. Well, when did we first hear about it? Dr. Gagandeep has spoken about initial deliberations that started in 2017. At the background, I think it was a Percy per cap meeting. I got an invitation in the end of 2017 to join this stakeholder forum consultation in Mumbai, the Tata Institute of Social Sciences. It was interesting because we were sitting together, about 35 or 40 of us from multiple backgrounds and from multiple sectors, from business and industry, academia, clinicians, ethics committee members, social scientists, members of media. It was an interesting 1.5 days. I think we ended with more confusion and more questions. For me, 2 important things came out of this consultation. One was the need for more scholarly research and more scholarly writing on the subject. And we had the special edition of the Indian Journal of Medical Ethics, which was dedicated to developing the ethics of controlled human infection models for low and middle income countries, which had multiple perspectives in about 10 or 12 articles. The other important thing that happened in 2018 was, a feeling that I had that while this group of 35 or 40 people were deliberating on challenge studies, what do we know about the people on the ground and their views? So in that same year, we initiated a study of the public perceptions of CHIM studies. And we conducted this in Bangalore, both urban and rural areas. I'll come to the findings of that study a little later. But what we did was take these findings and presented them and discussed them at the World Congress of Bioethics, which had people from across India as well as other countries. We also had people who were regulators and people who were decision makers within the context of India. One thing which came out of that work was, this is where we extended the study to see whether we understand perceptions of CHIM beyond a hypothetical CHIM study, which was what we used in the initial public perception study. So in the 2019 workshop that we had, we focused on specific CHIM scenarios. And these were not based on any decision that India had taken, but based on what we thought were completely different disease models. So we looked at typhoid, malaria, and chikungunya, which all have different routes of infection, different models of treatment, known and unknown. And again, we had the workshop model of deliberating the ethics of these 3 separate models. It's important for you to understand that this has also been published in the form of 2 reports where arguments on all these perspectives have come up. At the same time, or slightly later in 2019, as Dr. Gagandeep has mentioned, DBT has initiated the setting up of the Volunteer Infection Research Consortium in India. And that group, which I am a part of, continues to meet and deliberate on the way forward. Yes, there's been a movement from using the word CHIM to now volunteer infection research. This is just an aside, but yes, this is what was one of the small things which came out of that public perception study, that CHIM gave a connotation which was confusing. People associated it with the word chim and chimpanzee, and that was not something people wanted. They also used the word gym and wondering whether there was some physical exercise involved in these studies. So I think using the word volunteer infection research gives it a connotation which is probably truer to what we have already heard today. I'm going to move on now to the voice of the public and share with you something of what they had to say. This is a publication. That asterisk denotes that this is a publication. The voice of the people are not based on opinions that I have come up with, but it has been a rigorous exercise of a formal study that has been conducted. I'm going to share with you, because of the paucity of time, just a few key features that emerged from this research. The first was there was no outright rejection. People were fine once they understood what these studies entailed. Yes, we could go ahead with these studies, but there were conditions. And these conditions are important to hear. Safety was something that was a key concern. It was a priority. You've already heard from Dr. Shah's presentation how important this aspect is in the ethical decision regarding a challenge study. And again, in her study, she speaks about the value, the societal value. And this is what the public said in their own words, that it must serve public good. For them, it was just not stopping at good science or looking at agendas of industry, the pharmaceutical companies, but it must serve public good. Another point which came up was the choice of the disease. It must have relevance of public health interest in India. People have memories of the time when clinical trial studies were done of drugs which were not relevant to India, but done for purposes otherwise. So here they're looking at something which is endemic to India. Again, there's a but. And the but involved a disease which is known and having proven treatment. The other interesting point that was raised as a caveat was India cannot be the first country that does this, Jim. We need to have some data from other contexts, and only then will we feel confident. And again, this is what reflects the mood or the understanding of the way clinical research is done in our context, as well as the way the health system functions. There was hesitancy to participate. People were unwilling to volunteer themselves, but interestingly, yes, there was a but, they were ready to suggest who would be the ideal group to participate. There was that othering. The rural folk suggested it should be the urban people. They have access to healthcare. They can understand things which are as complex as this. The urban people felt, I think it should be good for politicians, for judges, for medical professions. They are inside the system. They can understand how it works. They can actually go forward if there's something that goes wrong. Remember, this is 2018. People said, but if there is an outbreak, maybe then if we have a crisis, either in our own families or people around us, then we might consider. So there was that aspect of altruism also expressed. Nobody imagined that we would be living through this COVID-19 pandemic back then. The next set of points that came up constantly were the ethical issues of compensation and consent, both considered extremely critical. But compensation had its ethical conundrum, and that with financial compensation, it would be almost inducement, almost like a livelihood opportunity for people. We have situations in India, whether it is for surrogacy or whether it is for organ donation, which involves these issues of payments being misconstrued and people being exploited for the sake of money. Interestingly, they felt maybe instead of compensation, can we look at insurance? There was a dilemma about what will happen to us in the long term. And again, the context here is the healthcare system of India. We do not have universal healthcare coverage. So can we look at something like healthcare insurance for the long term for participants? Consent. Dr. Shah has spoken about robust, informed consent. People said it's not just about information, but they emphasized that consent needed to be deliberated, not one time. It should involve questions and answers. It should involve not just me. We've heard about third-party exposure. We've heard about people being in isolation for 14, 17, 29 days. We need to involve the family. We need to involve the community. They even spoke about assent being given by the next of kin, so that there is a wider understanding of the implication. And that's what they meant by meaningful consent, to have the implications discussed and understood. And the third is about it being reciprocal. Consent is, yes, a commitment from my side once I sign on that document, and I have understood, I will continue, but can I have that same commitment from the other side to know that I will be taken care of, I will be assured all safety and protection. Right. I think what you might be saying are 2 points from what Dr. Shah and Dr. Kang have said. Is this really different from other clinical trials? Well, for people in this exercise of engagement, it was because they were given a chance to voice their views. It amazed me actually, because we went on to talking about changes and strengthening of regulatory mechanisms. And what really amazed me is that people had a lot to contribute to the strengthening of regulatory mechanisms. And I do feel personally that if what we do through strengthening regulatory mechanisms for challenge studies helps to improve the clinical research environment for the whole country, then so be it. I know I am often, shall I say, even ridiculed by researchers and reviewers. You know, you're going to collect this information on regulations and ethics from people who have no knowledge of science, and what do they know? Where is their data? Where is the evidence? But I am amazed, but yet it has been confirmed that what is the data of these people are their lived experiences. And that is the reality that they come with. And that is the reference point and the evidence which gives them the right, I shall say, to have these points of view. So the regulatory requirements as suggested through the people's voice is one, as you've heard, the choice of the disease, the choice of the strain, the dosage, the virulence, all of that has to be done with competence. So we need for that to be done systematically and scientifically. The next is the responsibility of the researcher, the research institution, the selection of this group, the monitoring of them, their responsibilities, and holding them accountable. That is another key requirement of the regulatory authority. The other is about public awareness and public engagement. It cannot be a one-time event that is held. It needs to be sustained, it needs to be done bottom-up, and I do think it can be done. With the challenges involved, if other contexts and other countries have done it, then so can we. It won't be easy, but yet it can be done. Compensation. Compensation, like we've heard, is complex, but we require it to be fair. We've done a fair amount of work. There was an interesting point raised here, which is if we don't want people to join just because it will be a livelihood option, can we not have the compensation amount disclosed at the time of the call or the announcement, so that that is not what entices people to join? And they spoke about the need for a regulatory body. Sadly, me being part of an ethics committee, I do feel it's sad. People were not aware of the role and functioning of ethics committees. They did talk of the need of having a watchdog. Interestingly, they used the metaphor of a watchdog, but they said a watchdog without teeth is not going to help, because that watchdog will get eaten up by the system. So what really they were talking about is the need to build trust and trustworthiness of the system. And I'm going to end with that in my concluding slide. But just want to tell you all, I've shared just a glimpse of what the public voice has been on challenge studies. The citation is below. This is just fresh off the publisher's table, actually went online last night. I do encourage all of you to access this article and get the details. It's going to be open access for the next 1 month. I hope with what I have shared of the public voice that you've understood what public engagement is and what it is not. To reiterate, it is not a one-time activity of public education. Secondly, it is definitely not, which most people think it is, a strategy for recruitment, a strategy for enrollment. That is a sales pitch, and that's just marketing and advertising. But rather, public engagement is a two-way process. It's of mutual understanding. It's of listening, it's of sharing, of purpose, not just of purpose, but also of results. This has come out very strongly in all of my research, that there is so much attention given at the time of recruitment, but after the study, we are forgotten. Sharing what you find and you share in your journals, you don't come back and share with us, nor you share the benefits. So I'm going to just also give you an idea of what else is possible as approaches and methods of engagement. This is work that we are doing right now. My colleague, Prasanna, is working hard to understand what actually are methods of engagement and what are the approaches. We're doing this work with collaborators from other countries, not just for challenge studies, but for novel biomedical research. I think as Seema Shah mentioned, ethics is always lagging behind and is trying to play catch. Can we, from bottom up, be prepared and be ready rather than react to something that comes out as a scam or an adverse event after the event. So engagement involves, yes, awareness with all of those methods and purposes, consultation, which is about the views and about the opinions, and stakeholding, where the public are involved in the development of the guidelines, in the monitoring. And like Dr. Gagandeep mentioned, yes, having those bodies like advisory boards, having deliberative mechanisms of not just one-time meeting, but following them up. You may be confused with me using the word people's voice, community engagement, public engagement. I think, yes, it's a matter of semantics, of what you use, but it actually comes down to the context that will define who the community is and how general the public is. I just want to say at the end that this work that I've shared with you is not about whether challenge studies are good or bad, whether there is a go or no go option. That was not the purpose of this work. It really to me threw up the fact that people have a voice, that they do have strong views on safety, on how they understand safeguards and what their expectations are of how good ethical research should be regulated. I think we should also remember that such challenge studies are not happening in isolation or in a vacuum. The context and the setting, in this case, India, is very important to keep in mind. And I'm going to leave you with the point of trustworthiness. And this is really what it comes down to. Not just individual trust between a doctor and a patient or a subject and the researcher, but really of the system. These are my last thoughts. And I thank you again for the opportunity and also to put onto record all the voices that have brought this together.
Thank you, Dr. Manjulika. Thank you very much. And for this excellent talk and the most important part of it. I now move to Sanchita. I think we are running short of time now.
Yeah, we have two quick opinion polls after this presentation. Would you be willing to participate in a challenge study? Request the participants to please respond. So 62% say yes. Next question. Should people be paid to participate in the challenge study? Yes or no, or can't say. %68% say yes. Over to you, ma'am, for interactions.
Yes. Thank you, Dr. Sanchita. Okay. We have had a lot of questions from the registered participants. More than 155 questions had come, and we have some during the chat box also. But the time which is available now is very limited. So we have picked up some of the questions to ask. I think maybe I could ask only one question to each of the panelists. But before that, I want to give opportunity to the panelists themselves. If any of you want to ask question to any of the other panelists, I think the first preference is to you. If there is no questions from your side, I'll go on to the participant questions. It's open to all of you. Any one of you want to ask from anybody else some clarification, some questions?
Now, I just want to say that I thought that community engagement and the outreach work is very, very important, and it was an excellent presentation. Thank you.
Thank you.
Thank you, Dr. Anna. Yes. Anything else from any other of you? No, I think there is no questions. Let me go on to few of the questions which I selected from this group. Okay. Dr. Anna, the question is that at what stage of an infection related to the degree of suffering and number of deaths justify a human control trial? There are so many illnesses, but still we choose a few of them for doing the human challenge study. The question is that what is the extent of degree of suffering or deaths which are happening will decide which are the infections which can be chosen for human control trials.
That's an excellent question. I think some of the ethicists will need to weigh on this as well, because it's not just the degree of suffering or death. It's, do we have the tools available to us to address that without a controlled or without a challenge model? And if the answer is no, that's when we really start to look at a challenge model to see if we can accelerate the development of therapeutic or preventive measures. So COVID-19 or SARS-CoV-2 is an excellent, I think, example of that. We've seen the extreme amount of morbidity and mortality from this virus. We know that we have to develop therapeutics and preventive measures as quickly as possible. And the question is, can we do that now in enough time, or do we need a human challenge model? And I will say that, you know, the communities involved, the scientific communities, the vaccine manufacturers, the regulators have worked together, I think, with incredible collaborative spirit to move these processes forward as quickly and as safely as possible, so that we're addressing the morbidity and mortality of SARS-CoV-2 as quickly as possible. I think the other side to that is the greater the illness and the greater the chance of death by a pathogen, I would say it's harder to develop a challenge model for that pathogen because of the risk that the volunteer would assume as participating in that challenge model if we don't have a therapeutic.
Yes, thank you, Dr. Anna. The similar issue now I want to ask Dr. Gagandeep Khan. There are two questions. One is, besides the absence of a rescue treatment, okay, what are the challenges of testing CHIM study for COVID-19? Since you are part of the guidelines, now this is the question, which is that in the absence of a rescue treatment, what is the major hurdle you think in having a COVID-19 challenge studies? And the question, that additional question is, do you think there are additional challenges in India which is different from the rest of the world? Why we are not having challenge studies? So these two you can answer.
Okay, so I will be brief in the responses. There are lots of challenges to establishing a COVID challenge model, but to start with the challenge strain, we don't have one yet that is well characterized. Developing that will be difficult. We cannot predict with certainty who is potentially more at risk. We know that there is a very small proportion of young people who can have severe disease and die. And right now we have no way of characterizing who that person might be. The virus itself is unknown. We are recognizing now that you see some people with prolonged symptoms after the acute infection. Again, we have no way of predicting who those people are going to be. So the risk is not quantified. The challenge agent is not ready. I think in terms of benefit, we have some sense of what the benefit might be, but because we don't completely understand risk, it is something for us to consider. Why don't we have challenge studies in India? I think the reason is that we don't have trust. We don't trust in clinical research. And to some extent, that's our fault. We didn't set up the system to do clinical research that was recognized to be ethical and meeting the highest standards of science, which is really to serve society. none of us are thinking about any kind of clinical research that does not move the field of medicine forward. The idea is to do better for our patients, and this is one tool that would allow us to do this in some unique circumstances. But as I said, it is our problem for not communicating enough, not building the systems that allow for everyone in society to recognize that if we were to do such studies, we would do them as safely as possible in the right kinds of circumstances.
Thank you, Dr. Khan. Next question I want to ask Dr. Manjulika. See, globally, there are a lot of individuals are registering for volunteers for COVID vaccine trials. Okay. But will this be the same, you think, if we have the CHIMs for COVID-19? What do you think will be the public perception? Registering for COVID vaccine trials and registering for COVID CHIMs trial, do you think people's perception will be same?
Well, I would not want to give an opinion about that. What are those factors that would influence people and their decision making? I think, when you look at altruism, it is sometimes a good thing, and sometimes it is where you misunderstand the reason behind making that decision. So I think that is what we need to understand. I do think there will be the same response, because I feel people will not really distinguish between CHIM versus a vaccine. There is a need to have something coming out fast. But for me, the most important point is that of agency. What do people have as the ability to question the system? And that is something that we need to ensure, that they not just comprehend in an intellectual way, but are able to understand what it means to be a participant. I haven't answered you directly, but I hope this is sufficient.
Probably this will be your next work to do, because in a COVID vaccine trial, people are expecting they'll be prevented from getting infection. In a CHIMS vaccine trial, you're going to be infected. So there is a basic difference between the two. Probably you will do the work in this. We'll continue. Next I move on to Dr. Seema.
I'll just add another point.
Yeah. Yes. Yeah.
The therapeutic misconception that is associated with all forms of participation in research. So this, I would say, yes, needs to be studied further, and we do need empirical work, so I'm happy to take that on. But this issue of therapeutic misconception is something that will come into the picture.
Okay, thank you. I move on to Dr. Seema. See, considering the current situation in what is happening with the CHIM studies, what is the global governance mechanism for dealing with the ethical, legal, and social issues will be the best for this? Every country having its own regulation at the moment, and people are also approaching it in different way. This is an area, if you think a global governance is needed, especially if looking into the ethical, legal, and social issues. What do you think should be the best mechanism of global governance?
Thank you, Dr. Vasantha, for your excellent moderation today. I think that this is a big hole in, especially legally, there are not great systems of harmonization across regulations in different countries. So there are a lot of differences, some may be more procedural than substantive, but in general, we don't have a good mechanism. So a lot of it ends up relying on voluntary cooperation, which of course in this moment is not, that kind of coordination isn't happening the way that it should be happening. So I think one possibility is the World Health Organization has been trying to convene different panels that people can go to for expertise. So that may be one way to try and achieve some sense of global coordination and agreement on when things are acceptable. The key criteria document is a good example of a document that could be applied in different contexts. And there are many other guidance documents like that. And I also think that for this consideration of SARS-CoV-2 controlled human infection studies, it could be really useful to have an international panel look at these studies and really vet them to see whether they are appropriate, whether their social value is high enough, there's not this confusion about what they could do, which we've seen in the past where people thought they really should be used to replace phase 3 efficacy trials. And now we're seeing that those phase 3 efficacy trials are proceeding and giving us really good data that we can rely on that's generalizable to the world's population. So I think these are the mechanisms that we have, and there's a great need to build more of them.
Thank you so much. Like we have the International Committee of Harmonization for Drug Trials. I think for CHIMs, probably we need a separate governance mechanism because it's more than the documentation of ICH. What we need here is the ethical understanding and the ethical perceptions which have to be taken into consideration. Probably we need a separate governance mechanism for the CHIM studies. Thank you so much. Now I think I hand over to Dr. Sanchita. I thank all the panelists for your excellent presentations and for responding to questions. There are some more questions, but we don't have the time for that. But I enjoyed the session, listening to all of you, and I'm sure all the participants also would have enjoyed. I now hand over to Dr. Sanchita to complete their the proceedings. Yes.
Thank you, Chair. I would like to thank the Chair and all the expert speakers for the useful discussions, which were highly informative for the participants. I request you to stay with us for a couple of more minutes so that I can make a few procedural announcements. Thank you all the participants. Request you all to kindly fill in the feedback form that would be available with you after you close this session. And your certificate for participation will be emailed to you by tomorrow. And the next webinar in the series would be on the 5th of November, and the topic would be ethical perspectives in planning and conducting clinical trials for cell and gene therapies on the 5th of November. The video of this proceedings, the video webinar proceedings will be available on the workshop website, which is nbmworkshops.com, and the details of the upcoming webinar will also be available there. With this, I thank all the participants and request all the chair and all the expert speakers to kindly switch on their videos so that we can have a group photograph virtually.
Thank you, Sanchita. Yes.
Can we have Dr. Ryder also with us, Dilip?
Dr. Christine, Dr. Ryder and Dr. Christine. Yeah.
I'm still here.
Dr. Christine Gadis, are you there?
Yeah, I'm here.
Yeah, she's here.
Yes,
Yeah,
Dr.
thank
Gadis.
you.
Yeah.
Thank you. Thank you, everyone. Thank you for your time. Have a very nice day ahead and good night to the other people. Thank you.
Thank you. It was a
Thank you.
lovely
Thank you.
session. I really enjoyed
Thanks
it.
all of you.
Thank you for a wonderful
Bye-bye.
panel. Everybody's talk was really,
Yes.
really good.
I was really impressed with everyone's contributions. Thank you. It was a great
Thank
to be
you.
a part.
Thank
I
you.
learned a lot too. Thank you.
Bye-bye.
Thanks to all of you. Thanks to Dr. Ryder and Dr. Christine.
Yeah, thank you to all. Thank you, Vasanta,
Excellent.
for sharing.
Yes,
you.
thank you, Vasanta.
Bye.